In the last couple of minutes of this segment, we'll take the simple question of which of these patients, once they get into remission, should be transplanted. So Anthony, you can take that on and give us your initial perspective on how you approach transplant now in both pH positive and pH negative ALL.
And so when I evaluate a patient for transplant, it's consider them either being pH positive or pH negative. So there has been so for pH positive patients, there's one randomized study from the Southwest Oncology group that compared hyper-CVAD with the dasatinib, and those patients who had a donor went on to transplant. Those patients who did not have a donor continued on maintenance therapy with the dasatinib. And from that study, it has shown that patients who went to transplant have a superior outcome compared to patients continued on chemotherapy. So up to the present time, at least for a Philadelphia positive patient, my bias would still be to take that type of patient to transplant unless the data from hyper-CVAD plus ponatinib can equal the survival that we currently get using a transplant.
So if you were referred a patient that was induced with hyper-CVAD and ponatinib, would you still recommend that they get a transplant?
If the patient had a fully matched donor, a sibling donor, a fully matched unrelated donor, yes, but any patient with a mismatch or a haplodonor, I would defer that until the patient for future if a patient relapses.
And we're assuming they're BCR-ABL or
the
MRD negative.
Yeah, obviously they need to be MRD negative and PCR negative.
Right. What about the pH negative patients?
Okay, so for patients pH negative, then we look at what the molecular and cytogenetics were up front. So so the main high-risk groups are basically hypodiploidy, 411 would be the two main poorer cytogenetics, and then depending on what regimen they got, you would look at the MRD status prior to either after induction or at week 16, depending on which regimen's being used. So patient who's MRD negative and do not have a 411 or who are not hypodiploid, that patient I would continue on an AY. So again, if I was going to use hyper-CVAD, then I think hyper-CVAD was designed more to take a patient to transplant. So if a patient's going to continue on an AY regimen, then I would not transplant that patient.
If they achieve MRD negativity.
If they're MRD negative.
Yeah, absolutely. What about the BCR-ABL-like lesions in that normal karyotype, older AYA population? How does that affect your decision making for transplant?
So that's you get differing opinions. So somebody who's pH-like, who's MRD negative at the end of the induction therapy, that sort of patient you may continue on chemotherapy. But that can be debated. In the last Alliance study, the pH-like patients did worse than than patients who were not pH-like. So that's, again, if a patient had a fully matched donor, either sibling, unrelated donor, I would take that type of patient to a transplant. But if they have anything less than a fully matched donor, then the risk of the transplant then the risk-benefit ratio may not be in the favor of doing a transplant at that time.
I think the pH-like story is certainly an interesting and evolving one, but I think...
And also they don't all behave the same way.
Right. So, the St. Jude's group has done the lion's share of the work in teasing out exactly what these lesions are and what the biology is. They published a study a few years ago where they looked back and they found that if you're pH-like, but achieve an early MRD negative remission, your outcomes are just as good.
That's correct.
Now again, so that's an extrapolation of children to adults, or if we're going to apply this to the young adult patient population. But the point you made initially of if you achieve an early MRD negative remission and you know that they're pH-like, if it were a patient I were treating, I would probably not refer that patient for transplant based on that small data, but recognize that because they're pH-like, they're probably less likely to achieve that kind of deep response. And then that MRD is what's going to trigger you to consider
Yeah,
sending
I
them
think,
for transplant.
yeah, I agree. I think the biology frequently declares itself. They may
Yes.
not achieve the MRD negative CR because of the pH-like lesion, but I don't think we can take pediatric data and just simply extrapolate it, because I think it's very protocol specific in terms of how those outcomes are achieved. And so I think, like Anthony, I struggle with it a bit, but I'm still compelled right now with the available data to probably transplant somebody as long as they have a well-matched sibling or unrelated donor if they have an identified pH-like lesion, because my concern is that if they do relapse and they're obviously at higher risk for relapse, recapturing that patient is more difficult. And so again, I think you got to take your best shot on goal right up front.
And I think that's what the data support, both in T-ALL, taking at both the genomic risk and the MRD into account when making decision making, and in that case, the RAS-P10 classification scheme, but also in B-ALL. Now, the recently published data, I think Mormon was the corresponding on that paper, the UK-ALL paper, showing that not only MRD, but also taking into account some of these very high-risk genomic lesions, which can influence the risk of relapse. Mm-hmm. Both were pivotal in driving that.
Mm-hmm. Right.
And Anthony, how do you decide whether to do a reduced intensity regimen or a full intensity regimen?
I mean, that would depend on the age of the patient. So at my institution, we basically, for patients under the age of 60 and is otherwise fit and healthy, that patient would get a FTBI etoposide regimen, because we've shown that patients, when we use etoposide for in the pH positive setting, when we use etoposide, you seem to get better results than using, say, cyclophosphamide. In a pH negative patient, we still use FTBI etoposide. That's become our standard regimen for the last 25 years. For somebody over the age of 60, we tend not to use whole body radiation, and I mean, our go-to regimen has been using a reduced intensity regimen using fludarabine and melphalan.